A warm welcome to Sitges and a warm welcome to the 5th annual meeting of the Heart Valve Society. It's great to see so many of you here from all across the world, all involved in heart valve disease. The title of this session is actually Back to the Future, and of course you heard one of my favorite tunes there, but it's really true for this meeting, because 22 years ago there was a comparable meeting in Sitges that actually started it all, as far as I'm concerned. And this is the program booklet, the front cover of that meeting in 1997, and you can see it was all about surgery. You see the surgeon standing in the middle, looking at fireworks, a human castle, and all these other beautiful cultural things that we have here in Sitges. At that point in time, I think we were on the merge of great things happening, great technologies starting to happen, and at the same time also friendships being made. And that's so important, we should not forget that. So let me show you what this human castle, because there actually was a human castle during that meeting, looked like. And that's it. So that was really exciting and really scary at the same time, I thought. Back then I was a very young scientist, and I actually presented one of my first abstracts at this meeting, and actually probably on this stage. I don't recall very well. What I do recall, the feeling of the human tower, and at the same time the feeling that I was standing on the shoulders of giants in heart valve disease, because there were some pioneers there that actually made this meeting happen and that actually formed the foundation of where we stand today with great technological advances and a broad global agenda. And I had the feeling I could see further, and it really inspired me to pursue a career in heart valve disease research. And then, I should tell you, this evening at the pool, we'll have the human castle again. Make sure to attend the reception after the meeting. We'll have drinks, we'll have food, and we will have the human castle. And that beats any soccer game, I think. I also, at that point in time, not only the human castle made me feel I was standing on the shoulders of giants, it were also these three men that dominated the meeting in a very great way. And I'm sure that José Pomar will talk about this infamous debate between Professor Carpentier and Professor Yacoub back then on stented versus stentless bioprosthesis. It made me realize how much fun research is at the same time, while it's really of high quality. And then José Pomar, I should mention his name, because back then he showed us it's not only important to bring people together to meetings to exchange scientific knowledge. It's far more important to make friends and to get connections and start networks. And that, I think, also has been a great inspiration to where we stand at as Heart Valve Society today. So a big thank you. And I'm very happy that Professor Yacoub is here today in this session and that José Pomar will also give a lecture. And we're going to look back, but we're also going to look forward. And when I look back at advances that have been made in heart valve disease research and clinical care, I think I should mention that already in 1997, 3D echocardiography was being introduced. And a lot of things have happened since in a positive way for imaging. And we're really entering an exciting arena when it comes to that. At the same time, in 2000, the first tissue-engineered heart valve was implanted in pulmonary position in a patient undergoing a Ross procedure. And look what has happened to tissue-engineered heart valves ever since. We'll hear a lot about that during this meeting. And actually, Professor Yacoub is going to talk about what the future will look like when we think about tissue-engineered valves. Of course, we all remember 2002, when Professor Cribier implanted the first transcatheter aortic valve in a patient. And he's here. And he's going to look back and share what has happened after this pioneering experience. So a very warm welcome to him as well. We're truly honored. Of course, after this pioneering event, transcatheter therapy has emerged and has really changed the way we think about treating heart valve disease. And it was the initiation of the partner trial, I think, in 2007 that set things in motion. And even today, and the very recent Partner 3 trial is showing that. We'll have a lot of latest news on this front as well. At the same time, great technologies. But we are a big world, and basically these great technologies only serve about 1 billion people on this planet. The other 7 billion are still facing different challenges. And this is a paper from 2012 by Dr. Eloy Marijon in The Lancet that told us that annually still 250,000 people die of rheumatic heart disease. And we have a responsibility there as well as a society. And we will take that responsibility moving forward. When it comes to our society, we're pretty young. 2015, it started because Heart Valve Society of America and the Society for Heart Valve Disease dissolved and became the Heart Valve Society. And our motto back then was, we are the heart team in action, a truly multidisciplinary team that wants to have a global impact. So where do we stand today? Great technologies, that's what you're going to see. Tissue-engineered heart valves, the latest in imaging. Of course, minimal invasive and robotic surgery. And, of course, transcatheter heart valve implantation, the very latest. That's where we stand today. At the same time, where we stand today when it comes to patients, we see, for example, that we are really at a point in time where you may wonder what will have more impact. Will it be the tweet that Mick Jagger sent out last week after his transcatheter heart valve implantation? Or will it be the Partner 3 trial? I think Mick Jagger will have more influence, but I'll take your bets there. We see in the Western world that we continue to age, live longer, and require more technology in order to live a relatively good life with high quality. At the same time, cost containment is an issue that we need to address. We have great technologies, but how can we utilize them optimally? And finally, there's these 7 billion other people worldwide that are still battling rheumatic heart disease, and we do need to take action there as well. And this will also be a focus of this meeting, how we can combine forces to not only address the latest technologies and scientific advances, but also see how we can make a difference in getting better access to care. So Heart Valve Society 2019. We are 670 members from 52 countries. So there's some diversity of perspectives. I really like that. And we've grown. I mean, we've almost tripled our membership in the past 4 years. Today, there are about 480 meeting attendees from all over the world. But we're more than just a meeting. We have 7 interdisciplinary valve research networks that are actually trying to join forces in addressing some of the burning issues that we have in heart valve disease. And they're meeting during the meeting here in Sitges. So if you see a valve research network and you think, hey, I may be able to contribute to this and join the team, then please go ahead and go to these meetings. Finally, we have one goal. We want to reduce the global heart valve disease burden through a heart team approach, and we'll continue to do so. I need to mention 2 valve research networks that are currently very active. That's Aviator, that's focusing on the treatment and outcomes of patients with aortic regurgitation and or aortic aneurysm. And they have grown in the past 5 years a database that now contains over 5,000 surgeries in this patient group. And we're trying to get insight into how we can better tailor treatment to our patients to provide them optimal outcome through standardized outcome reporting. And there's a new valve research network, Leopard, that is focusing on aortic valve replacement and surgery in general in young adult patients. Heart Valve Society 2019. You may have noticed that we have changed our logo and we are renewing the brand of Heart Valve Society. And as of Saturday, our new website will go live. We're also on Twitter and on LinkedIn, and I think we're going to increase our presence worldwide through these social media tremendously in the years to come. Also, in the last year, Structural Heart became the journal of the Heart Valve Society, the journal of the heart team. And I encourage everybody who's presenting research here to submit their work to Structural Heart, as it is our journal. And now looking forward, and we're going to look forward in this meeting as well. You know, Michael Jordan, one of my heroes, said, "Talent wins games, but teamwork and intelligence wins championships." And I think that is so true for Heart Valve Society and the community that we are growing. I think through networked science and the fact that we have a diversity of perspectives on heart valve disease, ranging from basic science all the way up to clinical application and outcomes research and trying to transform healthcare, that's what we try to aim for. So global impact through networked science and a multidisciplinary heart team approach, that's what we stand for. And that's because we want to have global impact. That's why we have decided for the next couple of years, we will be present globally. Next year, in spring 2020, we'll go to Abu Dhabi, at a place on the globe where there is access from Asia, from the Middle East, Africa, Europe. So making this society even more global than it is right now. 2021, we'll go to Miami, also not only serving Northern America, but also Middle and Southern America. And in 2022, we'll be back in Europe. So, looking forward even longer, in about 20 years' time, I want to go back to Sitges. I will be retired, and I hope you'll have me. And I very much look forward to the program we have then. And I hope to see another human tower. And I hope to see young people being inspired by the giants that will be there. And we continue to build our human tower. So my questions are, what will be the role of surgery and transcatheter interventions? I'm very curious. Will there be, or will we get closer to global access to heart valve disease care? Will we have eradicated rheumatic heart disease? I don't think so, but I hope we're getting close. Will tissue-engineered heart valves be the standard? Everybody is very enthusiastic about that. But will it actually make it? Or there may be new things coming along. Molecular, nanobiology, gene therapy, will they deliver new solutions for heart valve disease? Will there be standardized outcome reporting worldwide, and will it improve quality of care? Or is it just a hype? We don't know yet. And finally, will patients have become a member of our heart team? I think that's an important component that we need in our heart valve society. And I truly hope so, and that they will actually organize this meeting in 2039 together with Heart Valve Society. So I don't know the answers to these questions, but I do know that today and the next couple of days, we're going to start making formulating, of course, hypotheses first and getting these answers. And so I hope to see you back in about 20 years' time. And for now, I would like to wish you a very enjoyable meeting. Don't forget, it's not only about the science, it's also about getting to know each other and starting fruitful collaborations. Before I give the floor to José Pomar, I want to say thank you. I want to say thank you to our sponsors. I want to invite you all to meet outside all the exhibitors that are there. I want to thank PRI for the organization of this meeting. And I especially want to thank the leadership of our scientific program committee. Philippe Pibarot, Rebecca Haan, Marta Sitges, David Kalfa, and Carlijn Bouten. Thanks to them, we have an absolutely wonderful, diverse scientific program. And finally, I'd like to thank the young people, the young scientists who formed the branding committee over the past year and have made sure that our image is changing and that we're actually also having a presence on the World Wide Web. And I'm very grateful for that. So let's go ahead. Let's roll. José?
Thank you very much, Hanneke, for this really inspiring introduction. And I think we are really on the right track. I was always complaining from time to time, talking to the young people, and where you asking, you know who was Donald Ross, and tell you which team was playing, and you say, no, it was a cardiac surgeon. Probably most of the people forget today, probably it's a normal thing, what happened 20 years ago. That's why we were trying to remember what happened in 1997, as Hanneke was mentioning before. At that time, there was something called the Club Mitral. The Club Mitral was something organized at Bruxelles Hospital and later at Pompidou, and was on the hand of one of the pioneers of the, if not the big pioneer of the mitral repair, Alain Carpentier. And this is a brochure of this kind of meeting. A little bit later, there was another thing called the Scientific Committee for the Advancement of Bioprosthesis. And you can see here a young Alain Carpentier and a very young José Pomar on a podium in, I don't remember where it was exactly, but what is sure is that there was a group of very, very big people Some of them, unfortunately, are not here anymore, but Carpentier, who was the chairman, Bill Angel, Barrett Boyce, Larry Cohn, Carlos Duran, Bob Frater, many, and a stupid and young guy like me around there, and I was really feeling like a little fish inside of a recipient, not really knowing what to do. But in any case, I was asked to organize a meeting in Europe, and we had the idea, because of many reasons, to do it here in 1997 in Sitges. And as Hanneke was mentioning, we had a very nice poster. Basically, a surgeon was in the middle. At that time, there were not really too many cardiologists involved in heart valves. They were more concerned on the PCI or things like this. So we're here. And we have someone called Judy Vivian. Some of you who have more than 35, 40 years probably remember her. She was Judy Vivian, the CEO of a company called ProMedica International, and they were from Newport Beach organizing the meeting. A little bit like today we have PRRI in the US, but in a different system, because the problem we had with Judy Vivian, who was a very nice lady if you want, but the problem was that a month before this meeting, and we're planning to have 800 people, we realized that they didn't book any room at that time. So we had the lecture room, but no rooms for the people coming. So I had a big problem, and I had to go to find a PCO from Barcelona. We have him here. He's 80 right now, and I asked him help. And he was extremely nice, because he was not involved at all in this meeting, but he helped me to organize all the thing. We were able to accommodate 800 people. Thank you to the mayor of the city of Sitges. He was able to reorganize in the hotel, moving people from one place to the other, getting more hotels around. At the end, we were able to reorganize that. As it was mentioned, we had human castles. We have something called correbos, which is some bulls on the streets. We were able to close the whole area of Sitges that night, only for the meeting attendees. And we had an aperitif, then we had a dinner in different restaurants of the place. After dinner, we were having dancing until 2 o'clock in the morning, and we had fireworks from the Mediterranean Sea. That was really a very nice way of starting the meeting, the first night and everything. And I would like to, from here, to thank Jordi Bosch, because thanks to him, we were able to have this meeting. But not only this meeting, but also many other things. This was the beginning. This is the same room where you are today here. And when we came here was completely black, no light at all. And what we had was Carlos Mestres and myself from every side. You can get the music louder if you want. Just a second. Thank you. Thank you. So the idea was to explain to people what the meeting was going to be. That we were close to the beach. It was June, and the temptation was big, but we were here all the time. But at the same time, we were able to go down to the place and have some fun, as it was mentioned before, on the beach all together. Well, of course, Judy Vivian, who was here, is today enjoying a beautiful life in Hawaii, and it's not the same for many of the human beings, but she's doing extremely well. Alain Carpentier. Alain Carpentier is here, very young man. Some of the other colleagues around here on the beach, Eric Jamison, who was there too. Some of the people sitting here, like Manfred Dodge, I had the pleasure to have breakfast this morning with him. Peter Zilla, Bob Frater, or Bill Angel, they were extremely young in the meeting. And we have here again, Bill Angel, myself, we were just making a lot of fun in the beach. And this is a kind of a small little video of what it was allowed to be done at that time, something we cannot do anymore. And you will recognize some faces here, including Mike Musalen, who was 20 years younger, and maybe he was not even thinking he was going to be the CEO of Edwards. I don't think we were doing nothing bad. We were just enjoying a little bit all together. A competition between homographs, heterographs, porcines, and pericardial. So we're just trying to spend a little bit of time. As you can see, all of us were participating in this kind of Olympic Games there. Other people met here, the husband they have today. Nancy Poirier came here as a resident, and she confessed me a couple of years ago that for her this was a landmark situation, the meeting here, because he met his boyfriend, and they were extremely happy, and they are together since then in Canada. But I think one of the more fantastic things we had, that was mentioned by Hanneke, was the great debate we had just after the Olympic Games on the beach. Some of the people came with a bath suit here, and we had a big debate between stainless and stented valves. And it was not only a very good in terms of science, but also a lot of fun, and I'm sure there will be possibility of that. But the other important thing, Hanneke was mentioning the structural journal today, the structural disease journal. We had the Journal of Heart Valve Disease as a journal of as the scientific committee, but it was taking too long. It was complex to publish there. And we decided at that time with Alain Carpentier, basically, you can imagine, I was only following. We spent the summer holidays together here in Pals. We were able to review the whole manuscripts and the whole comments of the peer reviewers, and we were able to have 6 months after the meeting in December, we had the papers published, all papers published already in the Annals of Thoracic, which was a very good thing. Of course, this is a good thing, but not always everything is good, as you will see. One of the things was we had here a guy, Juan Comas, a cardiac surgeon from Spain, a pediatric cardiac surgeon, who was a connoisseur on bullfighting. He was able to convince Curro Romero, Alain Carpentier, and José Tomás. And Alain Carpentier, he became a connoisseur in the bullfighting. He was there. He was going to Nimes afterwards, and he has been since then a very crazy guy with that. But as I mentioned, not everything was good. Ender Borner, who was the one editing the Heart Valve Society, the Journal of Heart Valve Disease, was not happy with the fact that we published in the Annals of Thoracic, which is normal, and Ender Bonner was a little bit unhappy with me, because with Carpentier it was not easy to be unhappy, and he removed my name from the editorial board, and then in a way or another I was a little bit a part of the society. But it came when Magdi Yacoub became the president of the Society of Heart Valve Disease, which I have to say that there has been many precedents, but a very important man. Probably many of you don't hear the name only in the papers. Adrian Chester, he has been for years and years and years the soul of the Society of Heart Valve Disease, has been working, you cannot imagine how much. And I would like to make a very short and small tribute to Adrian, because he has been really very important. Magdi Yacoub became the president of the society, and then we went together to Paris, Magdi and myself, and we went to talk to Alain Carpentier, trying to convince him to stop with the scientific committee for the bioprosthesis and get together in only one society, the Society of Heart Valve Disease. I still remember the conversation, 3 hours at the Dome having dinner. He said, my friends, science has nothing to do with democracy, because we were telling that there's going to be a continuation, democratically elected members or councillors and so. And they said, but if you feel we should go to Society of Heart Valve Disease, let's do it. And that's why we were somehow disappeared one thing and we went up to the other. Many other presidents were there after Magdi, and the time when Fred Moore was there. I was going from time to time, every 2 years I believe, to New York to the meeting of the Heart Valve Society of America. But then two guys, a little bit of a mafia I have to say, Maurice Serrano and Fred Moore, they thought we should try to get together the American Society of Heart Valve Disease. And they called me here to Barcelona, come this evening to Berlin, we have to talk. And I went there and they said, well, you have been elected anonymously, president of the Society of Heart Valve Disease. I could be, my mouth was so big, you cannot imagine. I couldn't believe what was going on. But the fact is that we start talking with Jeff Borer, always in a beautiful and very nice atmosphere, in a very good way. And after 2 years, I think we were able to get together and sitting and more or less reorganizing everything. And this was in Venice, a lot of wind, by the way. You don't have so much problem here, but mine, it was funny. And in Venice, we were able to say, okay, we finished with everything, and we have the Society of Heart Valve Disease you have today, or the Heart Valve Society, you know, today, the Heart Valve Society. So we changed the name and everything. You have seen the program here. I think it's an excellent, fantastic program. And I just want to finish saying that 4 I's, important. Interaction was mentioned by the president a few minutes ago. It is very important. We have a unique situation where we can work all together, even if we are not used to work together. We have to do it. Innovation, research, and teaching. This is very important. Both are very important. And especially for surgeons, research, I think, if we don't do research, we are lost. We will disappear. So I think research and teaching is very important. Image, third eye. Image is also extremely important. You see how it's going up and up very quickly, and that's why we also have a lot of people from Image inside of the society. We have to get this thing with us. And just to finish, industry. I think we have been always thinking about industry as the payer of the events. And we have to even change the mentality of the administration. The people of the government administration, they think that there is industry getting money, surgeons or cardiologists or research doing the work, and they pay you because we don't pay you enough, or what. It's a stupid and silly situation. I think we have to show them that industry can be has to be our partner. We have to work with industry in a different world that paying a trip or a meeting like this. This is not the ideal thing, and in this sense I agree, but we have to convince them that we have to do together something better for the patients, and I'm convinced that we can do it. So just to finish, Hanneke, Rakesh, Marta, you are already doing and have in front of you a great mission to accomplish. You have a fantastic society. I think is the society with the highest potential in the heart valve domain all over the world, with passion, which I think is basic, and work, very important, will flourish. So the program you will see is not only good, it's really outstanding. It's a very high value volume program, high value program, and I am sure you will realize that at the end of this week, and next time you will be twice as many we are here. Thank you very much. By the way, I have only something to announce you, and this is that Madame Carpentier yesterday had an accident at home, and they are not able to come. They were regretting very much not to be able to be here. And Alain Carpentier asked Gilles Dreyfus if he could be able to give his talk now, which I don't remember the exact title. Maybe you can say that.
Well, let me do that, José. So a very warm welcome to Gilles Dreyfus, who I think was raised by Professor Carpentier. And he's going to give a talk looking back, how has the French correction influenced heart valve therapy? Gilles?
Good morning, dear Hanneke, José Luis. It's a difficult task because when you replace Carpentier and you're not Carpentier, you have to give a talk in his place. I hope you understand that it's difficult. Now, of course, everyone knows Carpentier. Everyone knows because the title comes from his, among many publications, this publication, which is nearly, I would say, the Bible of mitral repair, which was following an honored guest address at the AATS and was published in 1983. So what does remain from all this? Because there has been a lot of publication, and it's funny because I was thinking while preparing this talk that mitral valve repair and mitral valve disease, regurgitation especially, and in degenerative etiology, is still something that is not well known. We have been running courses for more than 10 years with probably most of European surgeons attending. When you have the mitral conclave, you fill an auditorium with 1,000 people. So it is still something that, though it seems that we have said everything, is still not completely understood. Now, what Carpentier brought, it's very difficult. I'll try to summarize that, but probably he was very much looking into the pathophysiology, whereas we are drifting today with the percutaneous intervention with treating regurgitation. So the etiology, of course, is the cause of the valve disease. And I think we have also to outline that we are talking in the name of 1 billion people, which is Western countries and America, but that there is the rest of the world which has other type of disease and are not really concerned by what some of the debates we're going to have or the topics we're going to have. The lesions are the result of the disease process, and the dysfunction is the result of the lesion. And basically what is interesting in this functional approach of Carpentier is whether you don't want to restore a normal anatomy, you want to restore a normal function. And basically, if you do understand that there are two types of dysfunction, increased leaflet motion and restricted leaflet motion, then you need to just address these two to provide a normal, rather better functioning valve. The main principle, I would say, it's first of all to analyze the valve, and we're going to see how it's drifted today, to resect the diseased area without any tension, to address the prolapse, to preserve as much leaflet as possible, and to restore the anterior posterior diameter with a ring annuloplasty, which basically changes the shape of the annulus from a permanent diastolic position to a permanent systolic position. And this, I know that there are many people who don't agree with this, still today. So, is surgical analysis mandatory? Well, I think yes. You might find the same lesions as the echo does find, but you may find complex lesions or subtleties that are missed by the echo. And this is a big issue because with the development of minimally invasive surgery, with the development of percutaneous technologies, you have to rely on echo. And as we know, echo is also dependent on who does the echo. You see this echo, it looks like there is a huge indentation at the level of P2 or P1, P2. And this is, you look at the surgical analysis and you find the same result. There is, in fact, a big indentation. It's an abnormal papillary muscle, and you see there is a prolapse of the anterior commissure to elongated anterior papillary muscle, and the echo there was quite reliable. But if you don't take the time to analyze, I tell you why, because you'll see when you now go deeper, if you don't analyze the valve, you don't understand the pathology. There is this huge papillary muscle there, which basically is going transversely. There's a fibrotic left ventricle right in the bottom, and by just reattaching the papillary muscle to the posterior wall, you achieve a perfect valve with no more prolapse of the anterior commissure. If you put Gore-Tex everywhere, you don't sort anything. So analysis of the valve is important. Sometimes you have different findings from the echo, and you see here you have a P2 prolapse, and you see it seems that there is a huge indentation again here. Now look at the valve. It's a plication of the valve. It is not an indentation. It's an excess tissue which makes that the tissue is not in the same plane. And we don't find, and the strategy for surgery is no longer the same. Now the evolution of the techniques from the Carpentier initial principles have really now come to two radically different strategies. Respect rather than resect, which was promoted by also one of Carpentier's assistant, Patrick Perrier, and resect with respect, which I did promote afterwards, because I think that we should resect, and resecting is not a mistake. So the problem is that now we are doing medicine with motos. And this is first, it's a big problem, because I don't know whether the medical field is made for that. The second point is that due to minimally invasive and smaller incision and 2D vision, there is no longer any surgical analysis. Resection is sometimes quite impossible, and Gore-Tex becomes a surrogate to a proper repair. This is a 27-year-old model from Russia. She spent 3 months in intensive care after this mitral valve repair, and you will see the result. There were 20 Gore-Tex, and the only part that was diseased, you see the Gore-Tex have ruptured here, the posterior leaflet is folded, the anterior leaflet is buried. The same patient, after taking off all the Gore-Tex, resecting the area which was diseased, and doing a sliding plasty and putting a bigger ring, and then you achieve a proper result. So with the same technology, you can have exactly the opposite results. This is a 2 Gore-Tex, 1 ring after 2 years. You see the result? The posterior leaflet is now overriding the anterior leaflet. It doesn't override the plane of the annulus. You have a severe MR. And what has happened? All the Gore-Tex have ruptured, all the ventricle has remodeled, and the Gore-Tex are now too long. So this is a true problem, is how do we apply these principles and don't get these results? Because if at 2 years you have these results, you kill the mitral repair technique. And this is the real issue. So the evolution of surgical technique, we came from quadrangular resection, very rarely now, most often triangular resection, sort of a drift from the French to the US correction. There is no longer any annular plication, which was, by the way, initiated by the sliding plasty. The point was to reduce the height and without annular plication. And however, the size of the ring, whether you plicate or do not plicate, should not be influenced by the technique, because it's measured according to the unfolded anterior leaflet. And then there is sort of a drifting, because a lot of people said if you put a ring, you impact on the ejection fraction and the outflow tract obstruction. And so some would advocate not to put a ring, some would advocate to put a band. The problem is, whatever you do, you need to reduce the anterior posterior diameter, and you need to have stable results and good long-term results. Now, these principles are really key. Have an harmonious closure line, and this with a posterior leaflet which is 1/4 as opposed to 3/4 or 1/3, 2/3. But this avoids SAM. This is not the ring that promotes SAM. It is because you have a too high posterior leaflet which promotes coaptation close to the outflow tract. And again, restore the coaptation height. How many manuscripts mention the coaptation height in their series? Virtually none. And the coaptation height has to be 8 to 10 millimeters. And the problem is that there is no coaptation height in the percutaneous technique that we see today. And this probably is one of the keys for good long-term results. So preserve at best leaflet motion. As you see, the posterior leaflet can move despite of the ring, and the coaptation takes place posteriorly. There are some very clever techniques that can do everything in the same time, like the butterfly technique proposed in Japan, where you can reduce the height, treat the prolapse, and preserve the leaflet. And this is a very intelligent one. How does it influence today? Well, this is more and more abandoned. Who does really care? I heard a live transmission a few years ago on percutaneous treatment of mitral regurgitation by cardiologists doing this, and they were arguing whether the mitral regurgitation was functional or organic. So if you start like that, it's a big problem. So most often it's never used, and as I said, we have jumped to conclusion. The aim today of percutaneous therapy is to treat regurgitation, whatever the etiology, whatever the mechanism, whatever the leaflets. And this is probably wrong. Now, as you see, the development of reconstructive surgery has been progressive and touching all etiologies and with all type of techniques. Some have been abandoned. Some are better than others. Now, the cardiologist today is trying to catch up, especially in the field of pathophysiology, and not to propose, like for coronary bypass, quadruple bypass or aspirin. But I don't know why I'm blocked on this slide. I don't know why. Okay, so MitraClip and CardioBand together are very rarely used, and probably if you wanted to do a mitral repair percutaneously, this would be the aim. French correction, basically there were many techniques for one lesion, and with minimally invasive and interventional cardiology, you most often have one technique for many lesions, and this has to be really analyzed properly. Interventional cardiology today only tackles functional MR, and we know that it's a ventricular disease, so this is a real problem, and segmental prolapse, and this is another problem. So, as I said, probably we would need to move, and this is the society where these things can happen. Surgeons should become echo specialists and be able to read echo, and cardiologists should probably, echocardiographer, should know surgery to help the interventional cardiologists. I don't want to make a fun of this, but I've seen that happening is, well, you treat the dysfunction and you have a regurg, you put one clip, it doesn't work, you put another clip, it doesn't work, you zip, and then if it doesn't work, then you send to the surgeon. And of course, we can have the same with the surgery, fail mitral repair, and the issue would be the same. Now, what I insist on is the surgical result, and this is a P2 prolapse with ruptured chordae, done by a robotic way, and as you see, there is no shortcut. You can analyze the valve, you can take your time, you can do whatever techniques you want. The robotic surgery allows to do the same as you would do with open vision, and then you can really tailor what you want. In this case, we want to have a P2 segment, which is the same height as P1 and P3. We can go to the papillary muscle and put Gore-Tex cord to the free edge to resuspend and treat the prolapse. So we treat the excess tissue, we treat the prolapse, and then in the end, you have a result which is exactly the same as we wanted to have, which is a good closure line, no regurgitation, and most likely a good long-term result. So you see how we see even probably better with the robot than you would see in an open standard sternotomy procedure. So as you see, the worst condition, you have the retractor, you have no ring, and there is no prolapse. You put a ring, which is not downsized, of course, and you have this result, and this is the echo. So this is what we're aiming for. Now, the MitraClip procedure never achieves these results. You see, this is a functional MR, and you see that this is the result afterwards. Now, I have personally, as a surgeon, to wonder why the surgeons have failed for 30 years to address functional MR through the valve, and the cardiologists have embarked again on the same topic. This is a MitraClip on a Barlow, and probably if patients are like this with a Marfan, had a triple bypass, aortic dissection, severely symptomatic, percutaneous technology is probably more favorable than surgery. There's no discussion about the risk factors that play a big role. Now, whether in the end the results of MitraClip is good, Is it perfect? You see there is no coaptation, there is tension on the leaflet, restricted leaflet motion, tension, and probably some residual mitral regurgitation laterally. It is not to criticize, it's just to say that we don't achieve at all the same goal with percutaneous technology as we do achieve with surgery. Now, about the philosophy, of course, there are the results, and this is the end. This is the goalkeeper. If you have, like Carpentier, 97% freedom from reoperation at 20 years, this is the goal of mitral repair. It's nearly to cure people. It's not a treatment that lasts for a few years or a few months. This was reproduced by Tyrone David, 95% freedom from reoperation at 25 years. And freedom from severe MR at 20 years is 90%, and freedom from moderate and severe MR is 70%. We have presented a paper in the ATS and published in JTCVS, and with a longitudinal study, we reached an overall survival of 87% at 10 years, and have a 94% freedom from more than 2+ MR at 10 years, and a 97% freedom from reoperation at 10 years. So these were the goals. And to finish, I'm not sure that this is the proper evolution. I borrowed this slide from Maizano. From open to video-assisted to robotic to percutaneous, it looks like the monkey is progressively becoming a man and standing on his feet. I think this is really caricatural. I don't think this is quite true. I think there are still indications for good surgery, proper indications for percutaneous technology, and they need to find their room. But basically, surgical mitral repair within center of excellence remains the gold standard, unless inoperable patients with degenerative MR should undergo surgical mitral repair. Percutaneous treatment, it's not a repair. It shows promising results in very selected patients, such as in the congestive heart failure shown in the COAP trial. And unfortunately, the future seems to be more promising for transcutaneous mitral valve replacement rather than repair, and I think it's the goal that the industry will achieve. It's a bit of a pity if it does happen, because it will kill mitral repair. This is just a word of caution, and I think, as José said, we need the industry, but we can't be industry-driven. Thank you very much for your attention.
Thank you so much, Gilles. And now it's an honor and a pleasure to invite to the stage Professor Alain Cribier, the pioneer in transcatheter aortic valve implantation. And he's going to share with us, looking back on the lessons that were learned from pioneering transcatheter therapy. Welcome.
Well, first of all, thank you very much, Johanna, José, for your kind invitation. It's a pleasure to be with you today, and really it's an honor. So, looking back, the lesson learned from pioneering transcatheter therapy, in the course of my long career, I had the opportunity of developing some interventional technologies in the field of non-valvular and valvular disease, but the two major ones were certainly the development of balloon aortic valvuloplasty, with the first in man in 1985, and transcatheter aortic valve in 2002. That was a very big adventure. And I would like to say that I totally approve this aphorism for Edwin Land: don't undertake a project unless it's manifestly important and nearly impossible. So from this adventure, I had multiple lessons. For the purpose of this lecture, I have selected a few of them, covering mainly the first part of the development in which I was very much involved. The first lesson is make sure that you get the right keywords to innovate in medicine. You have to have an ability of vision to detect unmet clinical needs and to imagine yourself as being able to bring solutions. For that, there are some keywords. Some ego, a bit of madness, a lot of conviction, passion, patience, perseverance, and self-control when dealing with the experts, which is a very important lesson. You also have to accept a lot of failure before you succeed in your search for a partnership and investors. And also, it's better if you have luck on your side. Lesson 2, take the advantage of your small but faithful and efficient heart team. We have in Rouen, at Charles Nicolle Hospital, the University of Rouen, a very small team of surgeon and interventional cardiologist. And with this team, having this team with me was a key of success for developing TAVI, because we had an incredibly high and rare relationship support and interaction between the surgeons and the interventional cardiologist. And you see, for example, this picture of the head of cardiac surgery, Professor Bessou, and the head today of cardiology, Professor Elchaninov. And this is an image that you cannot find in many places in the world. So what was the rationale for transcatheter techniques in aortic stenosis? The recognition of a major unacceptable unmet clinical need. As you know, aortic stenosis is extremely frequent, and we know that there is a very high short-term mortality after the onset of symptoms, but we have a solution, which is surgical valve replacement. It's one of the best surgical techniques, and offering life-saving treatment, low mortality, return to normal life expectancy, but we very well know today that a lot of patients cannot be operated on for many reasons. About 1/3 of the patients are today declined for surgery. But in the 80s, it was worse, because age per se was a contraindication to surgical valve replacement. For example, in our institution, 95% of the patients operated on in Rouen were below the age of 70 years. So all the other patients were dying in the hospital after multiple rehospitalization, and I find that absolutely unacceptable. So it's important to dare thinking out of the box, and this is what I did when I tried to imagine a simple solution to enlarge the aortic valve orifice by ballooning the valve. This is why in 1985 I could perform the first in-man balloon aortic valvuloplasty in a 72-year-old woman, very, very symptomatic, several times declined for surgery by the surgeon because of her age and also because of an associated coronary disease. You see here the first in-man balloon aortic valvuloplasty in September 1985. And luck was there, because these patients remained without symptoms for 2 years and returned to normal life. Of course, because of the success of this very first procedure, many patients were called back, all those who had been declined by the surgeons, and we had the first publication in The Lancet, which was followed by a memorable reaction of the medical community. Facing the success, certainly, then the failure. Never give up. This is another lesson. I had an active participation in the incredible growth of balloon aortic valvuloplasty in the world, but in 1991, there was an evidence of lack of long-term benefit. After a series of patients included in international registry, a number of publications on balloon aortic valvuloplasty, the story looked a little like the valve implantation today. The conclusion was that we could offer symptomatic improvement to the patients, less rehospitalization, but a single balloon aortic valvuloplasty had no effect on survival and led to early valvular restenosis. So balloon aortic valvuloplasty was progressively abandoned, and solving the issue of restenosis became for me an obsession. And I started thinking about the possibility of using a transcatheter aortic valve. However, there is another lesson. Always put the failure in perspective. More than 30 years later, this technique is not dead. We still have some clear-cut indications. The technique has been considerably improved. It can be done today with local anesthesia, small schist size, and a very short hospitalization. But above all, it remains part of many TAVI procedures for predilatation of the valve and for balloon sizing, for example. And there was a collateral benefit that should not be underestimated, the onset of rapid ventricular pacing that I initiated for balloon aortic valvuloplasty for stabilizing the balloon, and which was absolutely mandatory to develop the balloon expandable valve. Which optimal solution if you want to replace the valve? Don't be impressed by the challenge and claim your goals. This is another lesson. The goal was to implant a valve prosthesis within the diseased calcific native valve on the beating heart using percutaneous catheter-based techniques and local anesthesia. Of course, the technique was supposed to be applied in non-surgical candidates. At first sight, and everybody agreed on that, it was a crazy idea, probably impossible because of the heavily calcified valve, and very dangerous because of the surrounding structures, the coronary above, the mitral valve below, and the septum with the His bundle below. So how could I justify the idea of a stented valve? It was coming from a very simple observation that during BAV, high-pressure balloon inflation is always able to open circularly any calcified aortic valve, as shown on the screen here. So a stent with a high radial force could be used during BAV to prevent post-BAV restenosis. But a valvular structure should be attached within the stent, and the diseased valve should not be retrieved, but used as a support to anchor the stent. This was very original, I think. The stented valve was a challenging combination of balloon expandable frame and valvular structure. Then I had to convince myself and to convince the other, and it goes through the validation of the concept of intravalvular stenting in calcific AS. Autopsy study was a landmark to move forward. The question were, is a large size stent able to keep a calcified aortic valve open? Which optimal dimension of the stent? What would be the risk of stent migration? And this is what we done during the autopsy of patients who died of aortic stenosis, dilating the valve on the left, implanting a Palmas stent, peripheral stent, in the middle panel, able to open the valve circularly, and cutting the aorta longitudinally to check that it was feasible. If the stent had a diameter of 23 mm and a height of 14 to 16 mm, it was possible to protect the coronary arteries and not to injure the mitral valve insertion and the intraventricular septum with the His bundle. So this was extremely convincing. Also, forceps were needed to retrieve the stent, showing a low risk of device embolization. There was a cadaver study performed by Renu Virmani and a member of our startup, the PVT members, in Washington just before, on the days before the first case. And they wanted to prove again that the technique was conceivable. And you see what they did. You know, in this cadaver valve, aortic stenosis with huge calcification, the stent was able to open it circularly and pushing aside all the calcium. And the traction force of more than 2 kilograms was needed to dislodge the stent. So exactly the same conclusion. And from this cadaver study, I got the green light for doing the first case. In the course of these innovations, you have to consider designing and patenting your device. So this is the model of valve that I could imagine. A stainless steel stent, highly resistant to compression, a tri-leaflet valve probably, an external coverage, and a valve made of polymer of biology, or a biologic valve. With our surgeon, Professor Bessou, we conceived this model of stent corresponding to this drawing. And the interesting part of it was that when the valve was crimped over a balloon catheter, the diameter was 8 millimeter, making compatible the use of this valve through the femoral artery. So this was also something extremely important. Never be discouraged. Protect yourself from the negative opinion of experts. Keep going. During 5 years, I presented the project to all biomedical companies in the world, United States, Europe, India, Brazil, everywhere. And they had all the same conclusion, because the experts, cardiac surgeons, were steadfastly against the idea for the following reason: technically impossible and clinically irrelevant, major life-threatening issues, stroke, coronary occlusion, embolization, mitral and aortic regurgitation, endocarditis, and so on. It would never be approved by the FDA, and it was the most stupid idea, just forget it. So this was the conclusion of this talk with the experts. It was very difficult to keep intact my power of conviction when I met open-minded people: Martin Leon, Stan Rabinovich, Stan Rowe, 2 engineers and 1 clinician that you know very well. And with these 3 people, we decided to create a startup company named Percutaneous Valve Technology to develop the project ourselves. These are the founders of Percutaneous Valve Technology, and with the help of Martin Leon, we could get a first sign agreement with a small company in Israel. This company would develop the project and also were the first investors. Many venture capitalists came at the pro rata of the success later on. Extremely important, create a perfect translational research team with the engineers. And so we had a number of brainstorming meetings to discuss about the stent, about the valve, about the way to suture the valve inside the stent, to the delivery system, and so on. And after several trials, we got to the finalized device, the PVT valve that you can see here, a 3-leaflet valve, polymer, then equine pericardium, stainless steel stent, single diameter of 23 millimeter. And each iteration of this device was tested in the laboratory with new tools because it was a new technology. Then moving to the fundamental step of preclinical in vivo testing was a great adventure also. We had a big animal programs during 2 years with acute implantation of the valve at diverse cardiac sites. And we could also conceive a protocol allowing to study the valve in the arterial circulation over 5 months and to check the result. And the results after 5 months were extremely good. But we had to be aware of significant deficiency of the animal models for evaluating a valve, a percutaneous valve in human. No aortic valve calcification, degeneration, different anatomy, size on site of surrounding structures. Minor differences in physiology and anatomy can lead to profound differences in the treatment, safety, and efficacy in human. But you learn a lot concerning the vascular access, the guidewires, delivery system, procedural aspect, and anticoagulant regimen. Lesson 16, have nerves of steel to deal with the first human case, especially in a critically ill patient. This happened, as you know, in April 2002 in a very special case, 57-year-old man, cardiogenic shock, no ventricular function, a lot of comorbidity, occlusion, no femoral access at all, turned down by several surgical team, and failed emergent transeptal balloon aortic valvuloplasty in our center. So it was the most challenging decision of unplanned transeptal TAVI as a life-saving procedure in a young dying patient who had all current contraindication of TAVI. And after discussion with Martin Leon, he said, high likelihood of failure, but it just might work and save his life. Do it. So this is the first case. I don't enter into details. You have seen that already, but coming from a femoral vein, crossing the septum, reaching the aortic valve, delivering the valve, observing the disappearance of the gradient, and the fantastic tolerance of the procedure by the patient. And you have seen this picture a few minutes ago with a kind of resuscitation of this patient. Which lessons from this first clinical case? Optimal translation of our anatomic findings. No valve embolization, coronary occlusion, mitral regurgitation, heavy block, mild AR, paravalvular, excellent valvular function, and you can see here the first ever seen post-TAVI CT scan showing the placement of the valve in the subcoronary position. Remain stoic dealing with your country's health regulation to start the first series of TAVI. Just do it. The condition was to put on the table patients with imminent death, life expectancy less than 2 weeks, and using the transeptal approach, which was used in the first patients. We did a series of 40 patients with this challenge, demonstrating the potential benefit of this disruptive technology on a subset of critically ill patients with life-threatening comorbidities. The results were 85% of success of valve implantation, and from this series, we had 4 patients who survived more than 5 years and 1 who survived 6.5 years without any valve dysfunction. One of the last lessons, agree to see your baby grow in other hands, it's for his good. Edwards acquired PVT and developed new valves, new delivery system, new approaches. The valve that we sold to Edwards was changed to the Edwards Sapien valve with some different iteration of the previous one and a second size of 26 millimeter. And John Webb developed the transfemoral approach, whether Michael Mack and Frederick Moore developed the transapical approach. I was in the operative room on the first case of transapical approach, and it was like the devil entering into the OR. Stay committed in all advanced TAVI technologies and scientific evaluation. It means never lose your innovation of sight. Keep performing extensive training and proctoring programs in the world, adapted to each advanced technology. Keep pioneering new procedural approaches like the minimalist TF TAVI. Keep being involved in multiple scientific trial and registry. Have always a champagne ready to celebrate the positive result of each evidence-based trials associated with a growing acceptance of TAVI and expansion of indications. You know what I'm talking about. Partner 1 in high risk, partner 2 in intermediate risk, partner 3 in low risk. And finally, look back and be happy to observe that after 17 years, your crazy project has turned into an incredible breakthrough technology. The very final lesson, be happy to share with the media some particular case, like the implantation of the valve in Mick Jagger. And the title of this paper published in the French press was A Little Piece of Normandy in the Heart of Mick Jagger. I was very proud of that. Thank you very much.
Thank you very much, Monsieur Cribier. I have the pleasure also to introduce now Liesl Zuhlke from, she's a cardiologist, first of all, and she's leading the group in Cape Town University in Groshur, and she has been very recently elected counselor of the Heart Valve Society. So thank you very much. Welcome. She's going to talk about something also, it was mentioned before by our president, the problem we have with the treatment of heart valve disease, which is a real problem. What's going to happen in 2039?
Thank you very much. Thank you very much for the invitation to speak today. I'm deeply honored to be speaking among such luminaries, but also a special thanks for having a talk about access to healthcare as part of this initial session. So it's important for us to realize that for the majority of people with heart valve disease living in low and middle income countries, and here I use the example of rheumatic heart disease, this is a death sentence. And we have if we look at the Sustainable Development Goal 3, we actually have a precedent. Sustainable Development Goal 3 speaks about promoting physical and mental health and well-being and to extend life expectancy to all. For this, we must achieve universal health coverage and access to quality health care. We must leave no one behind. And so often we don't see many of the people living in the world. So just some interesting facts. Despite the fact that access to healthcare has been a fundamental human right since 1948, about 50% of the world does not have access to affordable and basic healthcare. About 100 million people each year are forced into extreme poverty. Those are people living on less than $1.9 per day, and that's because of their health costs. So having to provide their own health costs forces them into poverty. And about 800 million people, that's about 10% of the world's population, spends as much as 12% of their gross, of their own income on their own healthcare. So these are the numbers that are actually facing us every day. And it's not only in low and middle income countries. This is a report from 21 OECD countries, which includes most of the countries that you're from. And it's very interesting to look at this graph where we look at how healthcare access is pro-rich rather than pro-poor. And if you look at the three diamonds, we've got a circle, which is all doctor visits. You can see gentle slope towards pro-rich. GP visits, so primary healthcare, a little bit more towards pro-poor. But if you look at specialist visits, and that's across the entire spectrum, including the US, you see it's almost entirely pro-rich. And if we think about cardiology or heart valve disease, we're obviously thinking about the need for specialist services. So as I approach this in the next few minutes, I'm going to look at three areas. So I'm going to start with some points around access. Then I'm going to look at heart valve disease care. And then I'm going to focus on the aspect of worldwide, because I remain and am always, obviously, unapologetically African and here to represent low and middle income countries. So let's start with access. And again, here we look at access for all. This is a United Nations right. And again, to mention some of the road signs along the way. So in 1992, the United Nations declared universal health care as an essential priority. In 2015, with the Sustainable Development Goals, and I read out a sort of précis of the SDG 3, with the goal of universal health care in 2030. And in 2017, there was a further ratification and resolution signed by probably all of your ministers of health around strengthening dialogue with academia and with societies such as ourselves. So we have this already in place. If we look a little bit closer at what this implies, it actually implies timely use of personal health services to achieve the best health outcomes. And that includes three distinct steps. So the first is gaining entry into the healthcare system, so the immediate access into health systems. Then accessing a location where needed health systems services are provided, so that's availability. And then very important, and something that we stress throughout this meeting, is finding a healthcare provider that the patient trusts and communicates with, so that personal relationship is key. What are the barriers to access? So there's a whole variety based on race, ethnicity, socioeconomic status, age, sex, disability, sexual orientation, gender identity, and location. And that we can quite understand. But it's the lack of political will that sometimes is very difficult to understand when this is quite a clear need. The deference to expert opinion rather than evidence-based medicine principles, the inconsistent use of medical technology, especially when it can increase access, and then the lack or the inadequate amounts of real-world data. It's important to realize that universal health coverage is not free coverage for every possible health intervention, regardless of the cost, which sometimes people think it is. But it is, however, much more than just health. It means that we need to take steps towards equity, towards development and social cohesion. So if you look, I work with the Global Burden of Disease group, and in 2015, we looked at some of the global burden of disease data and looked at healthcare quality and availability. And it was very good to see that it has improved between 1990 and 2015. However, that the gap between those who have and those who have not have increased by about 25%. This is a depiction of healthcare access and quality index. And you can see the darker it is, the less we have in terms of healthcare access and quality. And it's quite interesting for this diverse group of people to look where your country is and see where you fit in this picture. What is very interesting is that Access 2030 has become quite a buzzword, and not only amongst the medical professions, but much more importantly amongst the patients. This comes from the European Patients Forum, where they have looked at access to healthcare and how they can work together with medical and funders to provide that. So if we look at heart valve disease care, so when we look at how we would define that, there's multiple definitions: organized provision of care, obviously around the healthcare professional, the maintenance or improvement of health. I quite like the last definition, including work done in providing primary care, secondary care, tertiary care, as well as in public health. So if we look at this, we've talked about this very strongly in this meeting and in other meetings before about the structural heart team. And here I've taken 3 examples from the literature. And these are very important. We look at this in rheumatic heart disease, where we've got 33 million people living with the disease at the moment. And you can see in this 5x5 grid, we look at all aspects of the disease. But it's underpinned by a view at the social determinants of health. We look at all the health systems, baseline health systems, primary, secondary, and tertiary care. And then overlying all of this is appropriate research. Because we know that as much as 1 in 10 people in the US is living with heart disease. And if we put that person right in the middle of the heart team, this is the way we should potentially look at heart valve disease care. I do think that we sometimes miss the allied professionals, especially our nursing colleagues, and I would surround that patient with that. And then the very important aspect of patients, family, and the community, and how we work together with patients in providing the best possible care. But doing this on the grid of social determinants of health, primary, secondary, and tertiary health, research, and then public policy, advocacy, and funding. So I'm just giving you a small example here of what we have done in South Africa with rheumatic heart disease. And we've looked at the entire continuum of care from the under 5 period all the way through to policies and Department of Health. And at the same time that we were doing this, our system was being reconstructed with a new focus on primary health care, HIV and millennium, and then sustainable development goals, because we were undergoing a huge reconstruction in our own country. The IMCI is the Integrated Management of Childhood Illness, and that was one of the elements that we used to integrate messages around rheumatic heart disease. And these were many of the others that we did as well. And so providing a more integrated approach, taking into consideration all of those elements, was probably part of the reason why we see a significant progress in reducing rheumatic fever cases in South Africa. But that would not have happened if it wasn't for the fact that our entire country has improved, our socioeconomic status has improved, and at least 3 million people have been lifted out of poverty at the same time. So let's look now at worldwide. So this is a graph, it's from worldmapper.com, where we look at the world according to a particular variable, and this is the variable of health professionals in the world. So you can see Africa, or the middle of Africa, virtually disappears when you look at it in this way. And when you think about how can we possibly provide access to the world, we often think about it in terms of health professionals. But maybe we should think about it differently. Let's look at sanitation. And you can see these are projections for 2030. Who will have at least basic urban sanitation services, universal access by 2030? And you can see the majority of Africa and India is still in the far from achieving category. This is looking at electricity. And again, the only region of the world where there will be more people without electricity in 2030 is in sub-Saharan Africa. Currently 586 million people living without electricity, and it is thought to be in 2030 that number will grow to 645 million. Water and access to water, again, a similar situation where you see a very different pattern to the rest of the world. So in order to turn myth into reality and provide global heart valve disease access to care, we need to think very differently about how we approach particular problems. If you look at every aspect of this graph, this comes from the World Economic Forum, you can see there's a combination here between healthcare delivery, I'm focusing on about 4 o'clock, healthcare delivery with human rights and sustainable development. And if we look at 2 o'clock, we've got values related to behavioral sciences as well as education and skills. So I would agree, and I'm sure you would as well, certainly listening to the last few talks, that this is possibly one of the most exciting periods in history to be practicing medicine. But the problem is that many of our new therapies have not yet translated into better outcomes, and they certainly have not yet translated into global access. So how do we make it into a reality? And some of these are the kinds of things that we need to start thinking about. And we need to do that in a multidisciplinary and interdisciplinary collaboration. And this meeting provides the opportunity to do that, to discuss, to disseminate, and to develop new ways of doing this so that we can also provide access to all. So in the final 2 slides, I would suggest that as you listen to all the talks over the next 3 days or present your abstracts, you put the patient back into the middle of the heart team. You surround them with nursing and allied staff, and you also think about patients and advocacy. But then we don't forget the grid of social determinants of health, multiple levels of care, research, public policy, and advocacy, so that we can do that, so that we never leave anyone behind. Thank you.
Thank you, Liesl. Next up is Michael Borger, who was actually the inaugural president of Heart Valve Society. And I've asked him to look forward, standing on the shoulders of giants, having listened to the talk by Professor Cribier. I've asked him to look forward and look at state-of-the-art aortic valve interventions in Sitges in 20 years' time. So go ahead, Michael.
Thanks very much, Hanneke, for the invitation to come and speak today to a very important group and a very important society from my point of view. It's a great privilege to be here. Thank you to the whole Heart Valve Society Council as well. These are my disclosures. My most important disclosure is, however, that I'm not a psychic. And making predictions is a dangerous game because you're bound to be wrong in many of your predictions. It's just a fact. But here's some interesting examples from the past. For example, somebody said in 1949 that computers may weigh only 1.5 tons in the future. And then there's this doozy from 1977 where somebody that should have known better said there's no reason for any individual to have a computer in their own home. Obviously, these predictions were wrong. But with predictions, you can just look at the data that is currently available to us, and this is something that we all know. The older we get, the higher the prevalence of aortic stenosis. This has been shown over and over again. And we also know that people are getting older in general, at least in the developed countries. So this is in Germany, for example, from 2017 to 2030. 17 to 2030, you see a marked increase in people over the age of 75 and a decrease in the younger population. And this is a pattern that is seen in many developed countries. So from those two slides, you can assume that we're going to see more aortic stenosis in the future, but we're also going to be able to diagnose it more readily. There are several companies working on deep learning algorithms for ultrasound, for echo probes, where you can have a complete beginner just simply position the probe on the patient's chest, and then these deep learning algorithms will know where to look for the appropriate images based on what it sees, how to analyze the aortic valve, for example. That information can be sent up to a cloud right away and then be analyzed by an expert who's thousands of kilometers away. And these screening technologies are also going to result in the discovery of more patients with aortic stenosis. So the title of my talk is Aortic Interventions in 20 Years. So in general, the future looks bright for those doing aortic interventions, but not for everybody. Obviously, TAVI is a huge part of our lives right now, and there is going to be even a bigger role for TAVI in the future. This just shows the data in Germany from 2004 to 2018. TAVI surpassed surgical aortic valve replacement already several years ago in Germany, and you see the progressive decline in the number of isolated aortic valve replacements being done in Germany, and this is sure to continue. In the United States, 2017, the number of TAVI procedures already exceeded the number of isolated aortic valves, surgical aortic valves, plus surgical aortic valve plus coronary bypass surgery. So TAVI has already exceeded that number, which is really incredible when you think about the fact that TAVI in many states in the United States is financially unattractive. And despite that, there is a huge wave of these procedures being done. Hanneke mentioned earlier about being able to stand on the shoulders of giants. I have the particular honor of being able to stand on the huge shoulders of a very big man by the name of Fred Moore, and he was a visionary. He not only did the first successful transapical TAVI procedure in the world at our center in Leipzig, but he also saw that this technology is resulting in benefits for our patients, and that we should be applying it in a larger proportion. And you can see we do about 2/3 TAVI and about 1/3 surgical aortic valve replacement at our center right now. Having said that, we are, of course, a referral center specifically for TAVI, and that partly plays a role here with our large numbers. However, I'm quite sure we have the world's largest experience with this procedure. We've done over 7,000 of them now. This is the papers, two papers that were just presented at the ACC meeting in March and simultaneously published in the New England Journal of Medicine. This is the Partner 3 study. I only just want to show one slide here showing not only non-inferiority but superiority for TAVI compared to surgery with regards to their very clinically important combined outcome of death, stroke, or rehospitalization. This was the core valve low risk trial, which was presented there at the meeting by Michael Reardon and published simultaneously in New England Journal of Medicine. This is just the 30-day outcomes, but you can see again that TAVI was superior to surgery for several very important outcomes at 30 days, including stroke, major bleeding, acute kidney injury, atrial fibrillation, and then all-cause mortality or disabling stroke, with the only outcome that was worse in TAVI being a permanent pacemaker. And when they followed the patients out to 1 year, there was non-inferiority for TAVI with compared to surgical aortic valve replacement in these low-risk patients. So what are the implications for us as cardiac surgeons? Well, we can say, well, that's not going to affect me. Probably not a good idea. Or you can say, hey, look, I have some mild problems with the way that you structured your trial, but that's also not being logical. These outcomes were clinically meaningful outcomes. Even if you look at the Partner 3 data and you exclude rehospitalization, which you could say, okay, maybe that's not as clinically important as stroke or death, TAVI was still statistically significantly superior to surgery. So I think the more reasonable thing for us to do is to recognize this is disruptive technology that came out of a crazy idea from Professor Cribier and Marty Leon and others at the time, but it has led to a very logical result. And we have to see how is this going to impact our care of patients in the future. I also find it a little bit disingenuous for the cardiac surgery community to say, hey, look, we're these great innovators. We do minimal invasive and robotic mitral valve surgery. We're ahead of the curve. We're doing great things here. But TAVI is terrible, and I think this is really a rotten thing, and you're risking people's lives and being laggards on the innovation curve. I'm sure there were lots of people back at the turn of the century in the locomotive industry that said that people that were trying to make airplanes into an airline industry, that you guys are crazy, you're going to kill a lot of people, but that doesn't mean that they were right. So what are the actual implications for us in the cardiac surgery community? Well, there is going to be less isolated aortic valve surgery, and there is going to be slightly less cardiac surgeons in the future, and we should start planning for that. However, we're not going to get away completely from cardiac surgery, at least not in my lifetime. There's still going to be complex pathologies that cannot be handled with a transcatheter technique, and we still need to occasionally help our interventional cardiology colleagues with complications. However, this is what you call progress. Progress, I saw a great talk from Steve Bowling recently in Dallas where he said, progress is always fair to society, but not always fair to the individual. So in this regard, progress is not fair to the cardiac surgeon, but it's fair to society. Just like in the future, as we get more automated driving algorithms, we're going to need less taxi drivers, but we're going to have less accidents and less people dying. So it's good for society, not good for the taxi drivers. So another way to deal with this is to say that cardiac surgeons should play an active role in these transcatheter technologies. This is my personal strategy. This was the strategy of Professor Moore, and this is a strategy that I would suggest to anybody who's in this room, not only because it's good for cardiac surgery, but it's also good for the care of our patients. So this is our system there. It's not perfect, but it works very well. We have carved out a separate department, which is combined and led by surgery and cardiology. On the left is the surgeon, David Hotzai. On the right is the cardiologist, Mohammed Abdul Wahab. And they meet every day along with their team, and it's a big team, every day at 4:30 p.m. to discuss the cases that they're going to do on the following day, and if it's better that this patient gets a transcatheter procedure or if they get a surgical aortic valve replacement. This is a picture, a screenshot from our computer program which monitors the operations that are being done every day. I look at this every day. This is not a special example. This is something I could pull out any day and I could show you any time. And you see we have in our 2 hybrid rooms 8 TAVI and MitraClip procedures, and our very talented team was done by 3:30 p.m. There is a lot of money to be saved also in this sort of efficiency, and this is something that we're seeing on a routine, everyday basis. Now, there may be some people that say, no, TAVI is still a bad thing. What are we doing? What about TAVI durability? This was a presentation by Danny DeVere that caused a lot of uproar in 2016 at the EuroPCR. Well, it's still not 100% sure if durability is an issue, but I can tell you at our center, where I said we've done over 7,000 of them, we're not seeing a big signal. This is looking at gradients over time up to 7 years post-TAVI and the development of aortic regurgitation. There are some that are degrading, definitely, but it's not the overwhelming majority of them. And this was a paper that was recently published in JACC where they had over 210 patients and they looked at freedom from severe or moderate structural valve deterioration, and you see there was basically no severe structural valve deterioration up to 8 years post-TAVI, and quite a respectable amount from freedom from moderate structural valve deterioration up to 8 years. So also for aortic valve interventions, I think that we're going to need more subspecialization in the future. This is just a fact of life. If you look at the Apollo 11, there was less computing power for that whole program than there is on an iPhone 5, which we already think is quite quaint. And The amount of medical knowledge has been estimated to be doubling every 10 years, the worldwide amount of knowledge. There's no possible way that one human brain can hold all of that information together, okay? So we are getting more and more specialized in the future. We are learning more and more about a smaller and smaller area, which to me means that we need to continue with the heart team. We need to be able to have people that are able to communicate from their perspective with their specialization in order to achieve the best outcome for that patient. So I think that the heart team needs to live on for several reasons. I also believe there's going to be an increasing focus on quality control in the future. I don't know how often we're going to have the volumes versus outcome debates, but at some point we're going to have to say, you know what? The earth is not flat. There is an important relationship between volumes and outcomes, and we have to stop taking our own narrow interests into account in order to try to fight against this data. I don't know of a single football player in the Premier League, a single basketball player in the NBA, or a single professional orchestra player who does their profession once a week. It doesn't exist. You cannot say that there is no relation between how often we do something and how well we do it. But in case you want to still argue with me, here's another paper from the New England Journal of Medicine last week. They looked at TAVR procedures being done in the United States over the last couple of years. And you see quite sobering fact here is that 250 centers in the United States alone are performing less than 50 TAVRs per year. This is probably not where people that are sitting in this crowd are going to be sending their mom. And more shockingly, we see that there's over 2,400 operators that are doing less than 50 TAVRs per year. Again, this is probably not in the best interest of our patients. I know that there are some limits to centralization, especially in developing countries or in large geographical regions in Russia, Canada, Midwest United States. But you cannot make the argument anymore that we should not be centralizing in places that are densely populated with lots of good quality healthcare, such as in Europe or in the coastal US states. In this paper, they showed a definite association between the hospital annual procedure volume and outcomes, with an approximately 20% improvement in mortality once you do 100 or more TAVR procedures. And then I can show many, many other papers, but this is also one from Euro Interventions 2 years ago where they basically showed their optimal range or optimal number of TAVR procedures was actually more. It was around 200. So centralization, do we have the political will for it? Difficult to answer. That's not very politically attractive to close hospitals, but politicians do understand money. And as I said, with these centralization, I firmly believe that you can also save money in addition to improving outcomes, and that this will eventually play a role. There are several other things that I don't have time to talk about. Each one of these we could talk about 1 hour alone. That will be very important in 20 years at the next Sitges meeting. For example, improved anti-calcification treatment, increased bioprosthetic valve durability. This is not just anti-calcification, but for example, as you see in this set of videos here, a TAVR that has been inserted into a bicuspid valve where it is a very spherical annulus. If this is going to have any negative impact on long-term outcomes, we have to wait and see. We have to be also looking at reduced valve thrombogenicity. That is, of course, the holy grail for mechanical valves. If we can ever achieve that, that would be great, but we've been working on it for a long time without being able to do it. But it is also important for TAVI. This paper from Circulation in 2017 used a mock-up of TAVI where they have showing the spaces between the TAVI cusp and the stent, and then the space between the stent of the TAVI and the native aortic wall. And this is the type of flow dynamics that you see, and you can see stagnation and possible areas for thrombosis. This is a case that I recently operated on after receiving an accurate valve. I had to reoperate on the patient because of severe paravalvular leak. Unfortunately, it had migrated a little bit. But here you see behind the calcified native aortic cusp in the non-coronary position, here you see we pull out a thrombus despite antiplatelet treatment for this patient. What is the implications of these subclinical thrombi? We don't know, but it's probably something that we want to try to avoid. Tissue engineering, of course, I leave that to the master, Professor Yacoub, but also alternative biosynthetics such as polymers, such as Gore-Tex. Are these going to be playing a bigger role in 20 years? I'm sure they are, some of them. And in addition, nanobiology advancements may also be very, very important. I don't know which one of these things is going to be dominating our discussions in 20 years from now, but I'm quite confident that at least one of them will be. And then finally, we also have to think about our strategy. Do we want to keep looking at a one valve for life solution, a mechanical valve where you do not need to take anticoagulation, or a bioprosthetic valve with limitless durability, or are we reaching the limits of that already, and should we be thinking about a one operation for life strategy where a person gets first a TAVI, then they get a TAVI and TAVI, then they get the one operation, then they get a TAVI valve in valve, and then they get a TAVI in valve. So, lastly, I just want to mention aortic artificial intelligence, because this is a very hot topic, of course. Will this be impacting us for aortic valve interventions? This is a great example of a program that was differentiating between dogs and wolves, and it was extremely accurate, except every time it saw this picture, it said that this was a wolf, even though it's a dog. And if you know something about AI, these neural networks, you can't really see them. There's a black box. But one researcher was able to figure out to at least try to find out where the program was looking. And this is what he found out. The program was only looking at this parts of the picture. Why? There's snow there. Every picture of a wolf in the past had snow in the background and none of the dogs. So he thought this was a wolf. So this just goes to show that you still need some human input in order to say what the correct answer is. And therefore AI, I think, will play a very important role for diagnostics, not such an important role for therapeutics, because there are several things that are happening during the procedures that we don't yet have information on. How many procedures, for example, the operator has done, how many coffees he or she drank that morning, whether or not he or she had a fight with their partner. These are some things that may affect the performance that are not yet known, but may be sometime in the future. So in summary, I do believe we're going to have more patients with aortic stenosis. I do think we're going to see more aortic valve interventions in the future, and TAVI will be the predominant force within those interventions, and there will be less isolated aortic valve operations, and therefore probably a few less surgeons, but I don't think we'll be completely eliminating our specialty within 20 years. I do strongly believe in resource centralization, and I think this will become more of a political issue within the next 20 years, and AI will play a role for our patients, but hopefully, or probably not yet for interventions, although that will eventually come. Thank you very much.
Thank you very, very much, Michael. Very nice lecture. It is now my pleasure to introduce you to someone who doesn't need any introduction. I was even thinking about saying the grandfather of the Heart Valve Society, but then rethinking, I believe he is the Heart Valve Society. He is a very good surgeon. He has been editor or on the editorial committee of most of the cardiovascular medicine journals. He has been doing a lot of innovation, research, still today, and talking about networking. You were telling before, I mean, I met him from time to time in a plane coming from 20 hours in Los Angeles trying to get some money from Rolex for the Aswan Institute. So, I mean, chapeau. Thank you very much, Sir Magdi.
Thank you very much indeed for the introduction. I really feel privileged to be standing here and to congratulate our president and the heart team for bringing this society to such high heights. It is a delight, particularly involving young people, not forgetting about the rest of the world, etc., etc. My talk today, given to me by Hanneke, is looking forward. Will heart valve tissue engineering have changed the world in 2039? Now, almost exactly 14 years ago, our president and myself tried to address the same topic. Will heart valve tissue engineering change the world? Now 15 years, almost 15 years, have elapsed, and that gives me an opportunity to try and reflect about the issues actually raised in this article in more than one way. The first, is it still valid? And the second, how much progress has been made or lack of? Now, in this talk, I'm going to be talking about life, whatever that means, strategies for tissue engineering, which consists of either recreating nature at all order, harnessing the power of nature, possibly achievable, lessons from nature, geometry, dynamism, and function. Now we are really privileged by a new generations of bioengineers, a lot of multimodality imaging, modeling, and a lot of tools, if you like. There are several models in progressing, obviously, but I will just touch on the hair-field composite component valve and look in the future, which is the topic of my talk. Now, life. Looking at life from where I am or from anywhere, it looks as if it imparts almost magical properties to the entire organism, to organs, to tissues, and my God, cells. If you look into one cell, it is just absolutely remarkable about the millions of molecules interacting in harmony to achieve that magic. I will continue to call it magic, at least for the time being. I put it to you that valves are no exception. We need life. We need magic. Now, how to achieve that? Up till now, this has been done by two strategies. One is to recreate nature. What do I mean by that? I mean that actually use living cells, and there is very little way of creating cells for the time being, although there has been this notion of artificial biology. You can start from DNA and make a cell. Well, good luck to you for the time being. It might happen. We need the Michael Borges of this world to take us into that dream. And the extracellular matrix. We're starting to learn more about the extracellular matrix and the fact that it is not just a bystander. It actually plays a major role in creating the tissue, both during organogenesis, but also during later in life. And that has led this notion of the ECM being not a bystander, and that there are several examples which has shown us that if you take away all the cells and then perfused by ordinary blood, my God, if that tissue you have just decellularized and almost destroyed by removing all the cells, if it is a heart, it starts beating. What does that mean? It means that the extracellular matrix did have all the information necessary to recruit cells not from stem cells, which is under a shadow right now for several reasons. Time will not allow me to talk about, but from blood, which has progenitor cells, including endothelial cells, and makes the heart beat. So that gives more impetus to harnessing the power of nature and the strategy of repopulating what is called intelligent scaffolds, something similar to ACM. I couldn't find a better word than intelligent, which we all need. Now, the lessons from nature, some of you have seen that slide previously. This was in an article in Nature which showed that the sparrow changes the size and shape of the wings very quickly during flight. The size and shape, the direction, and that allows it to pursue an incredibly precise flight path, which is just seems to be impossible for any other flying object. So, can that be achieved? That's a lesson we have to learn because the word dynamism depends on geometry, and dynamism actually are very, very closely related to function. Now, geometry and flow actually is termed passive dynamism, and we have learned that the only constant thing in biology is that nothing is constant. It's always moving, whether it's a cell, organ, or tissue. And in the valve, each component can actively and passively change its size, shape, and stiffness during the cardiac cycle. Is that important? There is growing evidence that yes, it is. But how is it achieved? It's achieved by specific cells and ECM and extracellular matrix, as I mentioned, and it's tightly regulated by a variety of things, including nerves, which you cut, but they can regrow, and importantly, by paracrine factors. Now, this classic drawing, which by Swanson and Clark some time ago, have evolved and evolved because it shows how important is both dynamism but also geometry. Now we can define geometry a lot more accurately in normal individuals of all ages using the currently available multimodality imaging combined with interpretation using very strong computers to model what's happening and interpret it. And that's just an example of a recent article we showed that combining modeling and multimodality imaging, you can define so many parameters in valves, either before or after intervention, including the wonderful the percutaneous valves, as we have heard from Professor Cribier in a beautiful way. Now I will end my talk by showing just one example, and this is not the only example going forward, to be trying to actually use nature rather than recreate nature. And this is following 3D pulmonary valve and aortic MRI and CT scans of the normal valve, seeing what is important and what's not important. We try with a group to recreate the normality, if you like, and then this is done in several stages, including a hybrid of nanofibers as well as a support which is integrated inside the jet sprayed nanofibers, modified as well by a variety of means like functionalization to enhance the intelligence, so-called, of such fibers. And there are many avenues available to that, including using synthetic material which can enhance the functionality using graphene and other molecules which can enhance the capacity of these fibers to function as a valve. In conclusion, therefore, I predict that harnessing the power of nature through repopulation appears to be the way to go for the time being, that geometry dynamisms are essential for long-term function, and that has been amply demonstrated if we want to look at the very long term by the Ross operation, because it's the only valve substitute which, as Don Ross predicted, is going to survive. For now, we have 44 years of continuous function, and therefore we have to take note of that, and then all the other factors need to be addressed. Now, I have to admit that to date, Hanneke, during the last 15 years since we've written that article, there has been progress, but it has been slow. Equally, it is accelerating. Why? Because there is more knowledge about the biology of heart valve, and Adrian Chester and other people in the audience have contributed to having that biology of the valve, knowledge of. And also there are more tools, and Michael Borg has mentioned a few bio-nanotechnology, decorating the scaffolds, etc. So it is accelerating. So what is my prediction? It's going to be available for use in 39, where you and the younger people will be there to witness that. Hopefully it will be achieved a lot more, a lot earlier, as we have heard the advice of Alain Cribier, if we go down that path of innovation, which he has shown us how, it will be achieved before 39. These are predictions, obviously, and as Michael said, we could be wrong, but I stand firm that tissue engineering is going to change the world before 39. However, there is massive need for more collaboration between all the groups trying to achieve this. Thank you. Are we going to have a panel here? Or,
I think we run out of time.
Or it's 10 o'clock?
Yeah. Thank you so much. And we're running a bit late, and so I propose we all meet for coffee, get to know each other, start building collaborations, meet old friends, and start changing the world. Looking forward to meet you the next couple of days, and have a great meeting.